In this lecture, we will talk about joints. Before I start that, just want to remind you about what Confucius said. Confucius, the ancient Chinese philosopher, our greatest glory is not in never falling, but in rising every time we fall. So there will be times, you feel you're losing the game, but just stand up and keep going. So let's talk about joints. What is a joint? The definition is it's two parts of the body combined together, or two bones joined together and fitted together. That is a joint. Why do we need it? It is for the support and it is for the movement. So like in our body, the two bones joined together and wrap with the ligaments, which is fibrous tissue. Then we got joints. So if we look at that, this is the Boy Scouts, tying knots, like they are wrapping two sticks together with the rope. The same thing, like if we put two bones together and tied with the rope, we have joints. So these are also forms of joints. And this is the functions of joints. It gives us the flexibility, it gives us the stability, and this is a photograph of a Mongolian girl. That's the beauty of joints. On the other hand, and this little baby who is born with arthrokyphosis, which is a clinical condition where the joints are stiff, the joints cannot flex or extend, like they are stiff. Although they are not progressive, they will not get any better, and that will make his life or her life very difficult. And these are the joints, knee joints, X-ray. On this side, it is a normal X-ray, which is showing two bones, and there will be ligaments, which are wrapping the two bones together. And that is also a form of joint. And now this joint is failing because there is no joint space in between two bones. On this X-ray, there is a big joint space, which is filled with the cartilage in between two bones. Now the cartilage are failing, and now we start getting the arthritis of the knee. Classification of the joint. The joint can be classified according to their structure, the way they are made, or according to the function. According to the structure, let's say if we use two bones joined together with the fibrous tissue, we will have a fibrous joint. If we join two bones with the cartilage tissue, we will just cartilaginous joint. And if we join two bones, but this is a special, and it has many characteristics, and we have to talk detail about this synovial joint. According to the function, syn together arthrosis, there is no movement. Amphiarthrosis, amphibious, which might have some mobile function, or diarthrosis, which is fully mobile joint. And this is a good table for classification of joints. Structurally, we know that fibrous, cartilaginous, and synovial. In fibrous joint, we have three subtypes. They will be suture, syndesmosis, and kyphosis. In cartilaginous joint, there will be synchondrosis and symphysis. Synovial joint, which is a special form of joint, we haven't talked about that yet. The types will be plain, hinge, pivot, condylar, settle, ball, and socket joint. And most of the synovial joints are freely mobile, and most of the fibrous joints are immobile, synarthrosis. So let's talk about fibrous joint. Two bones joined together and connected by the fibrous tissue. The fibrous tissue tying two bones very tightly together, and therefore there is no space in between two bones, no joint cavity, and there is no or minimum movement. The examples of these joints are suture, syndesmosis, and kyphosis. Let's have a look. Our skull bone, cranium, is made of multiple flat bones, and these flat bones are fixed together like a jigsaw here. And these are the suture lines. These suture lines are crossed by the dense fibrous connective tissue, and this is a suture. Suture joint, once we get all this fibrous tissue, we get ossified, and there will be no more movement. This is a form of suture joint we can find in the skull bone. The next form is syndesmosis. Syndesmosis means distal fibula and distal tibia. They are close together and they form a joint. They are rubbed with the ligament. This is the syndesmosis ligament. And this is a syndesmosis joint. When it comes to kyphosis, if we look carefully, the bone substance, which is mandible, which is the jawbone, our teeth has been impacted and punched into the bone, and which is fixed with periodontal ligament, periodontal teeth ligaments. So this is a form of kyphosis, which is immobile. I hope you understand this now. Cartilaginous joint, when two bones are joined by the cartilage tissue. It's very similar to fibrous joint. They are very tight together. There is no joint space. There is no movement. There is no joint cavity. Examples are synchondrosis and symphysis. Synchondrosis, syn mean together, chondrosis, cartilage, hyaline cartilage joining the bones, and symphysis, fibrous tissue and bones covered by hyaline cartilage joining it together. So let's have a look. If we look at let's say this is the proximal humerus, and we remember this is the growth plate, which is the epiphysis, which is the growing growth plate. And on one side, we have bone, and on the other side, we have another piece of bone. These two bones joined by the growth plate, which is the epiphyseal plate. And this is also a form of joint. And this is what we call synchondrosis, similar in the first rib and the sternum. Symphysis, the bone ends covered with cartilage, hyaline cartilage, and these two bones finally wrap together with the fibrous tissue. The same thing in our spine. Multiple vertebral bodies are lined together, and in between the vertebral bodies, we have fibrous and cartilaginous structure, and the bone ends, end of the vertebra, there will be blue-colored hyaline cartilage. So therefore, this is a form of symphysis. Synovial joint, as we say, there are special characteristics. Their bone ends, which form the joints, are covered with hyaline cartilage, which is articular cartilage. And the joint has a capsule, which is the surrounding of the joint, which keep the joint completely enclosed. And this capsule is made of two layers, outer fibrous layer and inner synovial layer. And inside this capsule, the capsule has created a cavity, which we call joint cavity, which is a potential space. Inside the Inside the joint cavity, there will be joint fluid, which is filled with synovial fluid, and ligaments inside the joint, which we call intra-articular, outside the joint, extra-articular, and sometimes in the capsule, which we call the capsular ligaments. And synovial membrane, which is the inner layer of the capsule, has rich blood supply, rich nerve supply. Therefore, a synovial joint is very sensitive to stretching. So now let's look at that. This is the bone ends. These bone ends form the joint. These bone ends form the joint. The joint surfaces which form are covered with hyaline cartilage, and we call that articular cartilage. And it is surrounded by a joint capsule, which enclose the joint and completely separate from surrounding structures. And articular capsule has two layers, outer fibrous and inner, which is green colored layer, which is called synovial membrane. And there will be a joint cavity, which is filled with the synovial fluid. So shoulder joint is a typical synovial joint that you can see here. Let's talk about synovial fluid. Synovial fluid is quite similar to sweat or urine, like they are ultrafiltrate of the blood plasma, and it is secreted by the synovial membrane. And cell in the synovial membrane will secrete glycoprotein. This synovial membrane is present in the joint cavity. This synovial membrane is present in the joint cavity, and this synovial membrane also can seep into the joint articular cartilage, which is made of hyaline cartilage. So that synovial fluid can seep into the hyaline cartilage and can seep out from the hyaline cartilage. That makes the articular cartilage soft because of the water content, and it will also lubricate the hyaline cartilage. A synovial fluid is an ultrafiltrate of plasma. It lubricates and nourishes the articular cartilage, which is made of hyaline cartilage. In normal healthy need, the amount of synovial fluid is just a thin film coating the joint inside, and which is less than 5 ml. And it contains hyaluronin, lubricant, protease, collagenase. And synovial fluid is non-Newtonian fluid, which is its viscosity change with the flow. So Newtonian fluid is something like water. Water's viscosity doesn't change with the flow. So now look at the typical synovial joint, which is a knee joint. In two femur, this is the end of the femur, inside the joint surface, covered with the articular cartilage, which is colored with blue. And the same we have on the tibial surface. We have the ligaments, and which are outside the joint, extra-articular ligament, which is fibular collateral ligament on the lateral side, and on the medial side, tibial collateral ligament. And you can now see the anterior cruciate ligament, which is the intra-articular ligament, and posterior cruciate ligament, which is some sort of extra-articular ligament. And we also have the articular disc. Inside the knee joint, we call it meniscus. On the medial side, we call it medial meniscus. On the lateral side, we call it lateral meniscus. And this is the dissected body, cadaver, and showing the extra-articular ligaments of the knee. And different types of synovial joint, which are plain joint, condylar, hinge, pivot, saddle, ball, and socket. So it depends on the shape, or depends on the movement, like non-axial, uniaxial, biaxial, or multi-axial. So let's have a look. The movement of the synovial joints is easy to remember. They will glide on each other, they will angle on each other, or they will rotate on each other. So I want you to have a look at these diagrams, which is easy to remember and nothing complicated. So now let's start with the plain joint. So inside our wrist, we have 8 small bones, which are called carpal bones. These 8 bones are arranged in 2 rows, 4 proximal row and 4 bones in the proximal row, and another 4 bones in the distal row. They are just gliding on each other, and they do not have particular direction. They will move from side to side, forward to back. Therefore, they are non-axial. The hinge joint, like our door hinge, it is something like our elbow joint. One direction, unidirection, flexion and extension. If we look at the proximal radius and ulna, the proximal radius and ulna, they form a joint, and the radius is kept close to the ulna by using an annular ligament. So radius will twist inside this annular ligament, and therefore it is pivoting inside. It is uniaxial. This is the closer look for the plain joint, non-axial movement, hinge joint, uniaxial movement, and the pivot joint, uniaxial movement, which is just rotation. Now, when it comes to the knuckle joints, which is the metacarpophalangeal joint, metacarpals are the bones for the hand, and phalange, the bone for the fingers. If you look at that, you can see some sort of ball and socket, but they are shallower, and their movement is restricted to flexion and extension, and adduction and abduction, so getting close and getting away from the body. So it is biaxial, 2-directional joints, and therefore, although they look similar to the ball and socket, they are called condylar joint. And saddle joint, like a horse saddle sitting on the horse, can be found in the foot. Yeah, it is biaxial. The last joint is ball and socket joint, which is the ball, which is the head of the humerus or head of the femur, which is joining with the glenoid or the socket, multi-directional, multi-axial joint. Condylar joint as a closer look. Saddle joint, now we can see the saddle here, and the multi-axial ball and socket joint. So what factors influence the stability of a joint? Of course, stability and flexibility, they have to be balanced. If it is too flexible, the joint can dislocate or dislodge from its socket. And if it is too stable and too stiff, then the joint will be difficult to move. When we talk about stability of a synovial joint, we need to think about static factors and dynamic factors. Static factors mean they will be acting on the joint at all the time, whatever the position or whatever we are doing. These factors are ligaments around the joint, labrum, which is the fibrous cartilage around the margin of the joint, and joint congruency and joint version, so the shape. Like, for example, hip joint, which is very deep, ball and socket joint, which will be very stable and difficult to dislocate. And negative intrathoracic pressure, which is created by the joint capsule, will have some impact on the static factors. Dynamic factors may depend on the position of the joint, which must acts and which must give the stability of that joint in that particular position. So muscles and tendons around the joint will give dynamic factors. Now, if we look at this is the head of the humerus, this is the glenoid, this is the clavicle, this is the acromion. Now the shoulder joint, which is called glenohumeral joint, has been dislocated from the socket. It is a glenohumeral joint or shoulder joint dislocation. Let's talk a little bit about bursa and tendon sheath. Bursa is a flattened fibrous sac, which is lined inside with the synovial membrane, which it's going to secrete synovial fluid inside the bursa, and if they are elongated, they will be called tendon sheath. It is just like a water cushion sheet, which acts as a cushion so that the tendon can run without attrition, irritation when it is running on top of a bony structure. So this is a bursa, which is acting as a cushion so that the tendon can run on top of a bone. And of course, tendon sheath runs along the tendon so that the tendon has been protected and has a good gliding movement inside the tendon sheath. So these are the ligaments around the shoulder joint. And look at that, the humeral head has been removed to show the glenoid surface, which is like a pear shape. The joint articular surface is covered with the hyaline, which is colored with blue. At the margin of the cartilage, we have a fibrous structure, which is called glenoid labrum all around to make the shoulder joint glenoid deeper socket so that we have a better stability of the shoulder joint. On top of that, there will be articular capsule or joint capsule around and ligaments, intra and extra articular ligaments around the shoulder joint to create stability. This is an arthroscope of the knee. You are seeing the meniscus, which is the fibrous cartilage, which is also called articular disc. And this is the lower end of the femur, which is covered with the hyaline cartilage, upper surface of the tibia, which is covered with the hyaline cartilage. So let's talk about articular cartilage. It's present in the subsynovial joint, temporomandibular joint, sternoclavicular joint, or knee joint. Because of these meniscus in the knee, it improves the articular congruency and it gives the stability of the joint. So now we are seeing the hyaline cartilage, meniscus, which is the fibrous cartilage, and now this is hyaline cartilage. Of course, this is nice and pristine knee, but once we use gradually using on the knee and the knee articular surface gradually worn out, and now the meniscus starting to get ridged. And this is the injury to the knee. Now we can see the hyaline cartilage, which has been damaged, and now underlying bone has been exposed. And as we know, this hyaline cartilage, they do not have direct blood supply. They have their nutrition from the underlying bone through the nutrition. And this cartilage cannot be repaired. A few less slides of the lecture. Now this is the shoulder MRI scan, which is cross-section or ACL section of the left shoulder. This is the right shoulder coronal section, and this is the right shoulder axial section. And now you can see the joint fluid. Fluid contains loss of water, water contains loss of hydrogen ion. MRI scan will pick up hydrogen ions and giving the high signal. And therefore the fluid is white here. The bone is a little bit dark gray here, and you can see the cartilage, which is dark color here. And if we look at that, the humeral head, which is colored with black area, which is the hyaline cartilage. This is the glenoid, which is covered with black cartilage, and we can see the synovial fluid here. We can see the acromion, we can see the end of the clavicle, they form the acromioclavicular joint. And now we can see the axial section, the humeral head, glenoid, and we can see the synovial fluid, which is a little bit more than what it should be. And now this is the dislocation of the acromioclavicular joint. Let's look at the elbow joint. Let's review. This is the lower end of the humerus. This is upper end of the ulna, which we call olecranon. We call synovial joints. So the joints inside the joint capsule, joint surface are covered with the hyaline cartilage. We will have a joint capsule here to make it a closed cavity. And we have a synovial membrane, which is colored with green. And we have light yellow-green color synovial fluid inside the joint cavity. You can see the bursa, which is protecting the tricep tendon as a cushion, water cushion bag between the bony prominence, and the tendon can rend without any attrition. Of course, these are the ligaments around the elbow joint. And this is a knee joint where we can see the extra-articular ligament, which is the fibular collateral ligament, tibial collateral ligament, and at the front patella. And inside the knee, we can see the anterior cruciate ligament and posterior cruciate ligament. So these are the intra-articular ligaments, and these are the extra-articular ligaments, which is giving the synovial joint stability. So cruciate, anterior cruciate going from the front to the back, posterior cruciate going from back to the front, crisscross. That's why they are called cruciate ligament, which is the intra-articular ligament. Strictly speaking, only the anterior cruciate is intra-articular, posterior cruciate is not an intra-articular ligament. This is posterior cruciate ligament, which can be seen on the MRI scan, and this is the anterior cruciate ligament, which can be seen on the MRI scan. Now, I want you to remember the causes of a painful swollen joint. Being a scientist, being a clinician, I want you to have an open mind. If you see a joint which is painful and swollen, I want you to remember trauma tumor infection, because these are devastating injuries to the joint. And there are many other causes like inflammatory rheumatoid arthritis, psoriasis arthritis, crystal arthropathy, gout, pseudogout, degenerative joint like osteoarthritis, hematologic like bleeding disorder like hemophilia, which is bleeding inside the joint, destroying the joint, and drugs like apixaban or warfarin, which can bleed inside the joint. So I want you to have a look at these diagrams at the back of the lecture. And now I'm going to stop. Thank you for your attention.